there's some general rules in chapter 13 and 14 that if you get those stuck in your head, I think it'll help you get a whole picture, get a whole understanding of the complete picture. And, some of the general rules is it's pressure difference between two ends of the tube that forces blood to go forward. Would you agree? And we have higher pressure in arterioles and less pressure in the veins, and we tend to go from arteries to veins, which gets back to the heart. Here we go again. So diameter of the tube has a resistance difference. The smaller the diameter, the more resistance. Arteries are resistance vessels and veins are capacitance vessels. There's just a lot of little tidbits throughout these chapters that we're going to point out as we go, and hopefully they'll start sticking to you. And a lot of the anatomy is going to be gone over in this chapter as well. So if you have your notes, I'm just going to glance through these notes. There'll be a few pieces of these that I'll elaborate even more on as we get there. But some of this, like it starts with 60,000 miles of vessels intertwined through trillions of cells. Now, I thought that's just a tidbit of information that probably the one thing you remember and I won't ask on the test, but it still amazes me that there's 60,000 miles of vessels in one body. Who calculated that? I have no idea. All systems work together to maintain 7.4. And this is another classic example. If this system fails, it'll drag other systems down with it all pretty fast. In this one's case, we have other systems start failing, it'll drag nearby systems down, and sometimes that's a much slower process. If this system goes down, everything's going to shut down pretty fast. Approximately 5 liters of blood in the system, and we've already talked about blood shunting out of chapter 9 through the fight or flight system, the alpha betas. 5 liters of blood is not enough to be everywhere at the same time. So the point they're going to make in here is we send blood where it needs to be at that given time. You ever cut your finger and think, well, that's not too bad, it's not bleeding, then look back down there in a minute and it is bleeding. The reason is you cut through some capillaries and there wasn't any blood in those capillaries at the point you cut it. But by the time you look back down there, it had shunted around and circulated around that there was blood in those capillaries. If we sent blood everywhere at the same time, we'd all die of lack of oxygen and lack of pressure. And that's the bottom line. Functions of the circulatory system, obviously some of these are, to me, they're pretty mundane or common sense, if you will. To transport oxygen, and the second one we've got CO2, but we could just say waste. It's going to take the good things in and the bad things out. Number 2, nutritive. It's going to get nutrients throughout the system. Number 3, excretory. There's waste all listed in number 3. Uric acid, urea are just a couple of wastes that we need to remove from the system. Regulation carries hormones to target cells. Protection against microbes, bacteria, and viruses. All your white blood cells are involved in that. We'll break those down a little bit further in this chapter as we get to it. Your second circulatory system is your lymph system. But there is no actual pumping organ here. Your pump is muscle contraction. If you move, lymph flows. If you become stale and not moving, then lymph is going to move very little. Same thing with the vein system. In the vein system, the blood pressure in the veins is about 2 millimeters of mercury on the average. It ranges from 0 to 10, but a 2 average. Now you think that's enough pressure to really push that forward? It's not. Get that noise off there. In the venous system, the average pressure is 2. In the arterial system, the average pressure is 100. And so to get venous return, the number 1 venous return pump mechanism is skeletal muscle contraction. So again, the more active you are, the less stale your circulatory system is. It's extremely important to become and stay active throughout life, as hard as joints may hurt, and arthritis may dig in. Get up and move around. So the lymph system is no pump. It picks up extracellular fluid, which is basically plasma, carries it, now called lymph, returns it back to the circulatory system. The lymph nodes tend to cleanse and filter the blood before it re-enters, because we don't want to throw trash back in the blood flow system so it can go anywhere in the body and set up infection. So we have filtering systems before the plasma, or the extracellular fluid, gets back into the system. And tonsils, thymus, and spleen are all listed as part of your filtering system. Now, do some of these get stopped up with infection sometime? I mean, how many still has your tonsils? More now than used to. They've used a little different criteria. At one time, oh, you have tonsils? We'll schedule you in and jerk those babies out. And I was in that era, but I think there was a reason behind mine. My wife and I both had our tonsils taken out, and so have all of our kids, and all of them by reason. Chronic and continuous tonsillitis. It's like they filter, and they get so full of crud, they can't even clean themselves out, they're so full, so we remove them. And for some reason, that helps us be healthy. It doesn't make a lot of sense to me. We just took out a filter so the crap can keep flowing, and now we're healthier? I don't know. It doesn't make a lot of sense, but their criteria is that you're gonna have to have this throat infection continuous and many times within a year before they even think about doing it. And they don't want to continue to hammer you with antibiotics is another reason. So those combination of those two things, they take tonsils out. But I do think there's some genetics out there that tonsils do their job and everything seems to go well, and you live your entire life with your tonsils and no big deal. But we got some bad tonsil genetics in my family, I think, especially when they're two and they're already snoring because the tonsils are grown together in the back of the mouth. That's not a good situation. So there's your tonsils. Plasma, and this is breaking down blood, what this is. Blood is 55% plasma and 45% formed elements. And the 55% plasma is made up of 90% water. So of that 55%, 90% of it's water. And the other components are the plasma proteins, such as albumins, globulins. That's my favorite because it's coming up here at the end of October. Right? Halloween globulins. Did you get that, Christina? Okay. My jokes keep getting weaker, but that's the best I can do. You have different kinds of globulins. You have gamma globulins, which deal with antibodies, and then there's another one called fibrinogen, which deals with blood clotting, which we'll look at the blood clotting mechanism here pretty quick. So those all make up the other 10%, or really 7%, and then 3% is dissolved gases, such as oxygen, carbon dioxide, and things like that, that's going to be dissolved in the plasma. And then your formed elements making up 45% of blood, that's red blood cells, white blood cells, and platelets. And of course, red blood cells are your most abundant. They have listed 5.1 to 5.8 million per centimeter per cubic millimeter. And tends to run a little higher in males than females, but they list that we reuse the iron to make that. The liver does that for us as we break down red blood cells, which we know the lifespan of those, right? What's the lifespan of red blood cells? 120 days. So as we break those down and recycle, we reuse the iron for that. Slightly less than females, it says. Liver and spleens, what's breaking these down, and 120-day lifespan. Then your white blood cells only runs about 5,000 to 9,000, and that will depend on the situation. These things can increase massively and yet go away as about as fast. Some of them just have a 3 to 9 day lifespan. Some may have several days, several weeks lifespan. It just depends on the situation and the white blood cell. The granular, which consists of basophils, eosinophils, and neutrophils, which we had all these in our first lab, live 12 hours to 3 days. So these show up when you need them, get the job done, and get the Sam Hill out of there. And if they continue to hang around, or we continue to make more as they die off in 12 hours to 3 days, If this continues, that we make more and more and more and more, there's some serious infection going on that we're not winning the battle on. And then the agranular leukocytes are your lymphocytes and monocytes. You've got your smallest and your largest in the same category. Lymphocytes are your smallest, and they can live up to 100 to 300 days. And monocytes, we don't really have a longevity on those, but they're the largest, and they kind of come in after the fact or right at the end of the fact and try to clean up the mess. They're very large and phagocytic. Your first responder is considered to be neutrophils, as far as the first one getting there and starting working on its job. Basophils we really don't know much about. It says most cells there, but you should put mast cells. And the theory behind the basophils is that they migrate to the cells where they become mast cells and produce histamine in times of tissue damage to cause inflammation. Now that's our theory. We ultimately really don't know that much. Eosinophils we know as allergies. If you have allergies, those are going to increase significantly. Neutrophils would be just fighting an average infection, and that'd be first responders. Lymphocytes are second responders, and monocytes would probably be your third and last responder in that situation. Hemopoiesis, the forming of blood cells. You have erythropoiesis occurs in myeloid tissue, and leukopoiesis occurs in lymphoid tissue, tonsils, thymus, and spleen. So erythro is dealing with red blood cells, and leukopoiesis is dealing with white blood, variety of white blood cells. And actually some of the white blood cells are actually made in bone marrow. There's a few, not a whole lot. But what they're really dependent upon is the thymosin that's produced by the thymus for maturation. So that's a big dependency. Unfortunately, with age, thymosin production decreases. And the white blood cells in general are specialized for viral infections. Now, we say that, and that's a yes and a no. There's exceptions to the rule. We'll see more in chapter 15, but there's certain, let's put it this way, there's certain white blood cells that are considered T cells that are specialized more in viral infections. And without thymosin, we produce less of those, which makes us more vulnerable to flus and multiples of colds and any of those viruses that become actually rather lethal killers as we get older. The flu has probably killed more people than any other disease when it comes to elderly people. So we developed the flu vaccine to slow that process down, and that's a guessing game on an annual basis whether it works or not. So, all right, now ABO blood system. The term agglutination means cell clump. That's what would happen if you have type A blood and somebody says, oh, you need blood, I'm going to give you mine, and I have B blood. They don't mix. They are co-dominant when they're together, but if you have A blood, you can take A blood or O blood, and then we get into the positives and negatives of the RH factor. So agglutination, if it's your blood agglutinating, that's not a good thing. It doesn't look good for you. RH reference to where they first found the factor, which was in the rhesus monkey, which is spelled R-H-E-S-U-S. So that's where it originated. And I have something listed here called erythroblastosis fetalis and ROGAM. So let's look at the ABO system. We know that we have A, B, AB, and O blood types, right? Everybody familiar with those? Now, you have A positive and A negative. You have B positive and B negative. You have AB positive and AB negative. And you have O positive and O negative. AB positive is your universal recipient. That blood type can receive any kind of blood that's out there. O negative is your universal donor. It can donate to anything out there. Genetically speaking, O is a recessive to A and B. A and B is dominant to O and co-dominant to each other. Only in that blood type though. If you have B blood, they can't just say, oh, all we got in the freezer is A, I'm just going to give you some A. Well, they just killed you. Isn't that nice to know? Yeah. So the positive and negative, the RH factor, here's the rule. Write this rule down, and it makes sense to me. It may not to you, though. You can give a negative to a positive, but you cannot give a positive to a negative. You can give a negative to a positive, but you cannot give a positive to a negative. Now what that's saying is, if your blood type is RH positive, it's saying that you have the RH factor. If your blood type is RH negative, it says your body's never seen the RH factor, and it better never see it, because it'll be foreign if it does. So if you're sitting here with A positive blood type, and you need a blood transfusion, and we don't have any A positive blood type to give you, what can we give you in replacement of A positive? O positive, O negative, and A negative. You can give a negative to a positive because all you're doing is giving A to A. There is no transfer of an RH factor. Negative means that A does not have an RH factor. Will you survive without it? Sure. You just need the A. And O being recessive, and most all blood types will carry the recessive O, unless they say they're homozygous A blood type, you can understand that they're going to be heterozygous with an O. And that's just the way they are. All right, now, the worst blood type you can have is BO. I'm just kidding. That was my other joke for today, so we'll go on from there. Too much for a Friday.
Especially if you haven't showered.
We didn't need to know that. All right, so if I give you an example on the test, and I say, Johnny has AB negative blood type, and he needs blood now, what bloods could he receive? Not all at once now, I can't. He can receive AB negative, that's very good. What else? O negative.
You said O negative was the universal.
That's a good answer for all of them, isn't it?
Well, I was just making sure that's
Before you killed somebody?
Yeah.
AB negative, O negative, what else? You can actually give this person, since that's close to the universal recipient, you can give it all the negatives they are. You can give it A negative, B negative, O negative, and AB negative. That's what you can give that person. But everything has to be negative. You throw a positive in there, we just call it agglutination, and we've got serious problems. So you're probably going to clot up entirely fighting that unnecessary transfusion. If a person is B positive, they can obviously take B positive, B negative, O negative, and O positive. If they're positive, they can take more than if they're negative. Negative limits them to negative only.
What about if you're O negative? What can you take?
O negative.
That's it?
Mm-hmm.
That's what I am.
Everybody wants you as a friend, but nobody can really help you unless they're O negative.
My dad's on it.
See, the rest of my mom and my dad and my sister, they're all, I don't think A or B positive. I'm the only one out of them that.
You know what that
Now,
means?
the question would be, can we genetically get that from the genetics of his parents?
It's recessive,
So
so.
is he really the child of those two parents? Yes, we can get that. So they're doing a lot of strange research with blood, and they're finding some strange stuff with it. So there's a lot of things that in 10 years from now that we'll say, well, at one time we didn't think this, but there's some weird stuff coming out of these blood types. But I did have a lady in class one time told me her blood type, told me her husband's blood type and her daughter's blood type, and there was no absolute way in what the knowledge we have today that girl was his. And she still denies this, it is his. I didn't argue with her, I just said, there's the facts, let's move on, because the class was going, oh my God, I can't believe she even asked that. Yeah, it was pretty sad, but there was no possible way it was his daughter. And she swears to this day it is. So maybe that's one of those things that'll be explained down the line in some of this new research that,
Hope somebody got a paternity test.
yeah, well, somebody went ahead and raised the child, whether it was his or not, I think is what happened. Needless to say, now the next topic here, y'all feel pretty comfortable about giving people the right blood types now? If you not,
I think we should test each other on what our blood types are.
does anybody know your blood type? What's your blood type? O positive. You're like more than 70% of the population. We're just average Joes and Janes.
Yeah.
I'm O positive too. What? And we have any odd blood types?
I'm either O or B, but I can't remember.
Well,
What's an odd
Tracy
blood
could
type?
sit there and say, "Well, I'm either O or AB or." That didn't help us a whole
Well, I
lot.
know what my mom is, and I know what my dad is, and so.
Well, let's
I'm
not
one-
go there. You may find you're an orphan child. What's
I have
yours?
A plus blood.
A plus blood.
Yeah.
A positive. It's not a rare one, but it's not the most common one out there either. You know what yours is? Not really.
How do you find
Anybody
out?
else?
I just find out 'cause I had kids, what I was.
And that's typically the case. I mean, used to, went and got a marriage license or something, they wanted to know your blood type. And the reason they did is because the next topic on our list there, erythroblastosis fetalis. So if they knew your blood type and mom was a negative blood type and dad was a positive blood type, then they'd actually put them through counseling before they'd let them go ahead and get married. And they'd tell them that with mom having a negative blood type and dad having a positive blood type, dad influences the blood type of the offspring. And if the offspring comes out with a positive blood type, we have a clash of blood types growing inside of mom. Now there's very little placental exchange. Now there is some, but there's such slight amount placental exchange with baby and mom in the first pregnancy that seldom is the first pregnancy harmed. But during the delivery, there's huge amounts of blood exchange with delivery of the placenta, and so baby's blood gets mixed with mama's blood, and mama's blood's going on, I knew there's something wrong with this deal, and builds an immunity against the positive Rh factor. So the next time mom gets pregnant and the baby is Rh positive, what little blood mix there is, the body sees it immediately and will cause a miscarriage. And so their counseling back in the day was this: now listen, if y'all plan on having children, there's a good chance past the first child you're going to have a lot of miscarriages. Until that child is a negative blood type like mom, which could happen who knows how many times, or it may never happen, you're going to have a lot of miscarriages. And so that's where they come out with found a shot that they can give you now called Rogam. And that's why they don't do blood tests on anybody now. They don't have to counsel anybody now, because if you are incompatible on those blood types, then, and they don't even check the father. Mom's negative blood type, they're just gonna treat it as if it's a standard procedure. Some doctors will give a shot in the 6th or 7th month of Rogam, just in case there's more exchange across the placenta. Some doctors will wait until the baby's born. They'll get the baby's blood type. If the baby blood type is negative, they'll give mom a shot. If the baby's blood type is positive, if the baby's blood type is positive, they'll give mom a shot. If it's negative, like mom, they won't have to give it a shot. And then there's those doctors that, well, we make mistakes in the lab, let's don't screw this up. We're gonna give her a shot anyway, which is not gonna hurt one way or the other, except in the pocketbook, it used to be about $100 a shot. So, because I paid for many of them, I know. I used to watch that really close, and I just gave up after a while. Just paid it. But they say the father influences that blood type more so than the mother. Now, I don't know how to prove that, and it doesn't really make a lot of sense to me. It's a 50-50 kind of flip the coin where you can get a mix. We can do Punnett squares all day and show the possibilities. But how father would influence it more than mother, I don't know. But that's erythroblastosis fetalis. The scenario must be, and I'll have a test question on the test, and you'll have to pick out the scenario. Mom must be negative, dad must be positive, and the child must be positive. That scenario is the only scenario that we'll have future problems with other pregnancies. If mom's negative and dad's positive and the first child's negative, no problems. If all the children's negative, no problems. except for the dad, he has a house full of negative children. Well, that's a problem. So there's erythroblastosis fetalis. Okay. Hemostasis, blood clotting. Blood clotting involves a lot of things. You have vitamin K and calcium's involved in it. Kind of go through a breakage. If there's a damage to tissue, like they claim breakage of endothelium, there's 3 hemostatic mechanisms. First of all, the area of damage will try to vasoconstrict to slow blood flow down. Makes sense. We don't want it to gush out, so we try to slow it down. We try to create a formation of a platelet plug, and then eventually a fibrin web. Now, during injury, endothelial cells release a Willebrand factor. Platelets become sticky. Platelets begin sticking to the edge of the wound. ADP, which is a spinoff of ATP, it's based off of glucose. That in itself makes things sticky. You ever felt the blood? As air dries it, it's sticky, isn't it? Well, that's the glucose that's in it that's making it that way. Serotonin and thromboxane are released and cause a vasoconstriction. That says vasoconstruction, but I guess we're going to rebuild it at some point, but it's actually vasoconstriction. Other platelets become sticky and form a plug. So in the formation of the actual clot, platelets release prothrombin. Here's the sequence of events. Prothrombin activator, which triggers prothrombin to activate in the thrombin. Thrombin now triggers fibrinogen to activate in the fibrin. And what we end up with, we have a wound here, and this wound, blood's coming through it. We get this sequence of events. It's a chain reaction, a domino effect, if you will. Fibrin finally attaches to the walls of the wound, and as the blood flows through it, slower now because we have vasoconstriction, everything starts becoming sticky, and the blood cells stick to themselves as well as the fibrin, as well as the sides of the wall, and starts building that what we call a scab. And as the red blood cells become more exposed to air, they dehydrate. And when they dehydrate, still stuck together, their bond is very strong, they'll actually pull the sides of the wound closer together. And so now a wound that used to be that big is that big with a scab on it, less scar tissue, and we have our own stitching ability. So you flip the scab off and we create another one, but you'll create more scar tissue the more scabs you scrape off. And scar tissue is not very stretchable, so it's not real flex. Fibroblast is what scar tissue is. So this is extremely important for this to happen, and one of any of the factors is missing in the chain reaction, we don't clot. Now, you've heard that, what does aspirin do to your blood? That's the most common misnomer of aspirin. It doesn't thin the blood. Drinking water thins the blood, dilutes it. What aspirin does is reduce the stickiness of the blood. Okay, so it flows easier. And it's just easier for doctors to say, oh, it thins the blood, because thinning blood makes sense, it'll flow easier. Instead of going into an explanation when they've got to see 49 other patients today, they'll say, oh, we're going to give you this, it makes the blood's going to flow easier, it'll thin it out, and it'll squeeze through cracks that you're developing by atherosclerosis, and you're a lot less likely to have a blood clot enterally. Okay, so it reduces heart attacks because we get better blood flow. But darn, you sure don't want to cut yourself. You'll bleed like all get out because it reduces that stickiness.
What did you say caused the stickiness?
ADP. And ADP is ATP that we've talked about before, adenosine triphosphate. This is adenosine diphosphate, and it's all based off of glucose.
So then does it decrease the glucose?
It doesn't decrease the glucose. Glucose is just being used for something besides energy in a cell here. It's being used, as we know, sticky. Anytime you drop sugar on the floor, it's sticky. Hey, don't you love to spill Kool-Aid on the floor where a quart of Kool-Aid has a cup of sugar in it?
Especially if it's red.
Yeah. Sticky. The body even knows that. So, but that aspirin today, now, what is the standard amount of aspirin? If a doctor's going to prescribe you one aspirin a day, how many milligrams is he prescribing you?
It's the baby aspirin.
81 is the technical, and they actually make it. Used to, when the research first come out, they just said a baby aspirin. A baby aspirin was 86 milligrams, and I'm sure you can still get baby aspirin, but what they recommend for heart patients is, of course, all these companies come out and made the level that they researched to be the best. We can still get some blood clotting, but we still get good flow. There's a happy medium here, is 81 milligrams. Now, there's a lot of people out there, and I hope you don't know somebody like this. If you do, stop them. But they hear an aspirin a day, it keeps heart attacks away. And they know they've got a lineage of heart attacks. Dad died of a heart attack at 58, his brother's already died of a heart attack at 47, and I'm 60, I don't want to die of a heart attack, so I'm gonna take me an aspirin a day. Now, it's not good if he's taking a 300 milligram aspirin, which you'd take for a headache, and he's taking that to prevent, he's getting some serious blood flow. I mean, that heart not have to work real hard to pump this liquid. This liquid is flowing like crazy. But if he ever cuts himself, he's in serious trouble. On top of that, you can just touch him, and he bruises. That's how thin this blood is, and I use that term because it's easy to recognize, but we've got red blood cells squeezing through capillaries now. And I knew a guy that did this one time, and it's a classic case. His dad died early of a heart attack. His brother had already passed away of a heart attack. And he didn't want to be the next one, so he started an aspirin a day regimen on his own, which is not a bad idea in his situation. He's not ever had any heart problems at this point, but he don't want any either, because their heart problem was one time, heart attack, dead. So he didn't want to see that. He even got his wife on a aspirin a day. And I see him one day, and he's got these huge bruises on his arm right here. I said, man, what have you been doing? Oh, I've been building a building out back, just me a little storage shed, and I thought I'd put me an air conditioner in it. Never know when the wife may kick me out of the house, just one of those kind of inside jokes. And I said, well, lifting an air conditioner, a small air conditioner up in a window should not bruise you like that, unless somebody dropped it on your arms. He said, no, I just lifted it up in there, and I thought that was kind of weird that it bruised like that. And I knew about his heart history. I said, what are you doing different? And he said, well, I started taking aspirin today. I said, how many milligrams are you taking? Oh, just a regular aspirin. I think they're like 300 milligrams. I said, you're killing yourself. You're internally bleeding to death. Scared him to death. He shifted really fast to, I think he backed off aspirin for a few weeks to get it out of the system. Then he went to an 81 milligram aspirin. He's still going strong today. Lord, all you had to do is look at him and bruise him. And then, can you imagine his wife? She was bleeding to death. Internally, externally, it wasn't good. But we got them fixed. They're both still alive and proud grandparents today, so they're still kicking. So there's your chain reaction. You can see a lot of these are plasma proteins with prothrombin activator converting prothrombin to thrombin, thrombin converting fibrinogen to fibrin, and the fibrin creates the mesh network. Now, one last question on this before we move on. Which type of wound would clot faster? Well, let me redo this. A wound that's smoothly cut with a sharp instrument, or a wound that's treated by a dull instrument, which is more tearing of the flesh instead of cutting of the flesh? Which one will clot faster? Smooth? Does everybody agree? Does anybody disagree? This is not a right or wrong situation, it's a learning situation, so if you disagree, speak up. Some of you's not speaking at all.
I'm undecided.
Undecided. Typical voter.
I think the tear.
You think the tear? Amber, you always have to be different, don't you? I thought we had the class all on the same page here, but you just have to throw a cog in the wheel. And you're right. This one will clot faster. Granted, it's not kosher for a doctor to use a dull scalpel when he's doing surgery on you because it creates more scar tissue, but that will certainly clot faster because there's more surface area for the fibrin and blood cells to connect to. Now, hopefully when he gets finished doing surgery on you with this really sharp scalpel, hopefully he'll sew you back up. And he'll pull these edges much closer together by the suturing process, and by the suturing process, we will tighten that up. And the actual sutures themselves will be a contact point for the vessels. for the blood to attach to and clot, what small crevice that will be left there. You know, a lot of us accidentally cut ourselves. Well, worst cut you can get's a paper cut, isn't it? Is that a sharp edge? Didn't seem to be, but it sure cuts you like a sharp knife. And those kind of things like that seem to bleed the worst. You ever cut yourself, you girls cut your legs shaving?
Oh, God.
Yeah, well, you ought to try cutting yourself shaving after your wife cut their legs shaving. You know, they use the same razor and they didn't tell you. Well, we scrape ourselves to death. Well, she cut herself with a sharp knife, sharp razor. So we get the dull one and take the whole hide off. That's just not right. So I bought my wife an electric razor you can't use in water. I said, here you go, honey. That's me. She figured it out. Sharp cookie. So, yeah, when you cut yourself with a little bitty razor, it's just a little nick, isn't it? And it just bleeds like you'd cut yourself right down to the last vessel. Bleeds forever. And we come out, of course, we come out of the bathroom with toilet paper all over our face trying to stop bleeding because we just scraped ourselves to death. My daughter used to come out of the bathroom using a whole box of Band-Aids. It's like, are you ever going to learn how to shave your legs without cutting them all to pieces? And she had her own razors. It wasn't dull or anything. She just didn't get the right angle, I guess. And well, there goes half my leg. It's hilarious. All right. I know. Moving on over on more notes. Just some comments here. Strong clots pull tissue closer, which may force out pus or serum. And hopefully it prevents a lot of infection from getting in there as the clot is created. We don't want the clot to form over a lot of debris or dirt or germs. The first thing we should do when a cut or something is open, an open wound, is cleanse it as much as we can and keep it clean, so when it does create the clot, then we're closing over clean and clean tissue that has been disinfected. Factor VIII is the most common cause of hemophilia. Factor VIII is the most common cause of hemophilia. Now make the comment that aspirin reduces clots because it reduces stickiness. So we have learned to mimic factor VIII. If a hemophiliac needs surgery, you think, oh, I don't want to do that one, but we can mimic factor VIII on a temporary time frame so they can clot back after surgery and keep it in their system for quite a while to be able to do that. And of course, anytime anybody has surgery, which creates tissue damage, you have a greater chance for clots, and so they'll keep you on some type of blood thinner. It's anticoagulants is what it is, whether it be heparin or some other kind. And then you still hear of those people that they've healed up from open heart surgery, they pack their bags, they get up to walk out of the hospital, walk home, and they collapse on the floor dead. What happened? A blood clot broke loose from some interior stitching process, went straight to a brain or a vessel in the heart, either create a heart attack or immediate stroke that killed them. And it still happens. As many precautions as medicine can take today, it still happens. And a lot of people walk out unscathed. They're in great shape when they walk out, and then there's a handful that made it through the surgery fine, recovered fine, did well. Been out of intensive care a week, grabbed their bag to walk home, killed over dead. And that's exactly what happened. There's not a thing anybody can do about it either. It's done. Two pathways here. Intrinsic produces clots and damaged vessels where collagen is exposed to plasma, and extrinsic, shortcut chemical that is not part of the blood released by damaged tissue. And if we've actually mentioned both of those. I don't go into depth on the test on intrinsic and extrinsic. Just want to give you a general idea of what it takes to clot. And if you have that general idea, you're good. Now, breakdown of clots, resolution of clots, kallikrein and plasma. And it converts plasminogen, which dissolves plasmin. It should say plasmin clot dissolved. Kallikrein converts plasminogen to plasmin. And plasmin is what eventually dissolves the clot. That is our first step in trying to break down a clot that may have occurred anteriorly in the system. We'll try to let the body do it naturally. And then we may start adding heparin or something like that that will go ahead and dissolve and prevent other blood clots. Has anybody ever had a blood clot in a leg or arm? From what I can gather, I've never had one, and I hope I never do, but what I've gathered, people that's had them, is that it's extremely painful and very life-threatening too. Anticoagulants, heparin, coumarins are both listed. We're gonna run across several of these in the book as we start in the book on Monday. And coumarins compete with vitamin K. It's gotta be given several days in advance. It's probably the most common drug given to stroke patients. Unfortunately, by the time it really kicks in and starts working, they may have already had another stroke. There's not an immediate, quick response that we can really do for stroke patients, except get blood pressure down, get them calmed down, and get them sit down, don't let them do anything until coumarin can kick in. Then we can gradually start back in a normal life if the first stroke wasn't so severely damaging that they're not functional. So, and blood pressure has a lot to do with strokes. Don't do like my grandmother did. My grandmother's one of those, she go, go, go all the time. Even into her 80s, she was go, go, go. And then my grandfather passed away, she was even more go. And she'd go and see kids. And she had 5 kids, I don't know how many grandkids, I lost count. She's going to see them. And I didn't blame her, but she had high blood pressure. She carried pills in her purse. Grandma, you been taking your blood pressure medicine? Oh, I can tell when my blood pressure's up, that's when I take my pills. That's not the way you take medicine. You take medicine to keep your blood pressure at an even keel. You can't take it just immediately. It's not like a headache, an aspirin, or headache, and ibuprofen. You continuously take this blood pressure medicine to keep it at an even keel all the time. Well, she ended up with multiple strokes, and she could, her mind thought pretty well, but for her to speak what she was thinking on her mind was extremely frustrating for her. So she ended up with some severe speech problems, but she could understand what I was saying to her. But for her to turn around and tell me a story back became frustrating to her. Fortunately, I'd heard most of the stories, so I could kind of help finish the stories for her. But the strokes significantly decreased her quality of life. And I don't think she'd ever had one, or she'd at least prolonged it to older in age if she had continuously taken her medicine like she was told to do. So don't be a victim of that situation. And that was just simply a poor decision. She was one that did not like to take medicine. She did not like to go to the doctors, and that's the way a lot of older people are. Pretty stubborn when it comes to that. So mark your book right there, and like I said, we'll cross the anticoagulants in the text, and we'll look at it in there. We got some more circulation stuff to do. These are long chapters. We're talking about 3 class periods per chapter, knocking these things out. So we're going to be a while getting into test 4. One thing, go ahead and turn that off, Tracy. I'm finished.